First of all, I would like to thank you for your kind invitation to your prestigious conference, and it's a pleasure for me to be here in Ljubljana. And to be honest, I'm a little bit excited because, as far as I know, I'm the only pharmacist here at this conference, and it's a little bit different than in our family because I'm coming from a totally pharmacist family. My father and my mother are pharmacists, my sister, her husband, and even my wife is a pharmacist. So you can imagine, for example, Sunday lunch, what we are discussing during the time, and it's not always happy to be a guest at our house because every time we come to pharmaceutical issues and pharmacy. I'm working at Semmelweis University. I'm the chief pharmacist at University Pharmacy, and I'm also involved in pharmaceutical care developments in Hungary and pharmaceutical advisor of the Health Ministry. Now I'm representing Eurofund Forum. As Diderik mentioned, I'm an advisory board member of Eurofund Forum Primary Care. So, what about Eurofund Forum? Maybe you should know that this is the joint network of national pharmaceutical associations, and it collaborates with WHO Euro. Diderik mentioned WHO Euro many times in his presentation. What we are trying to do that translate WHO Euro priorities into the everyday pharmacist work, and we try to implement those through the national pharmaceutical associations. In my lecture, I would like to focus on what could be the potential contribution to pharmacists to safer, better primary care and to manage our patients. I will highlight some of the society needs. Why should pharmacists be involved? What is the concept of pharmaceutical care? Some evidences and also Hungarian examples, and how to step forward with wider collaboration. I think we all know that some of the modifiable risk factors are responsible risk factor causes of disability-adjusted life years, like tobacco use, alcohol use, physical inactivity, or obesity. So we need better primary prevention. And we also know that, unfortunately, many times, many chronically ill patients are undiagnosed or diagnosed late, even hypertension, diabetes, and many other chronic diseases. So there is a need for collaboration to have the diagnosis in time for our patient. And when we are focusing on drug use, it could be a major problem or a major harm because of the consumer society, because of the marketing models of industry and the media. The over-the-counter drug use increasing rapidly. But at the end of the day, because of the inadequate use or the overdose, it can make more harm on that. And many times, OTC drugs are responsible for the interactions, let me say two very common examples like acetylsalicylic acid and osinocumarol warfarin, or the other minerals with osteoporotic agents, so we should be careful. We also know that the ratio of elderly population is growing, and of course our patients using more and more drugs. Polypharmacy in the other is very common. That's why that the odds of being hospitalized by an adverse drug reaction is 4 times higher than for young girls. And many times the over-the-counter medication used by elderly is not identified. And I can say that in many countries in Europe, you can use over-the-counter medication not just through pharmacies and pharmaceutical advice through any shops, petrol tanks, whatever. And Also, low health literacy is the strongest predictor of individual health status. One of my favorite studies is when pharmacists give very easy advice. The patient takes 2 tablets 2 times. In the low health literacy group, only 35% of the patient could demonstrate the number of pills in their hand, that it means 4. So, and we can imagine it is very simple advice, and many times the drug regimes are more complex, how to take it, how to use it, food-drug interactions, whatever. In chronic diseases, WHO investigation, the non-adherence rate is around 50%. So the Pharmageddon is, in economic aspect, that in EU yearly 1.2 billion euro lost because of non-adherence, because not adequate use of medicines. And just to pick up a Portuguese study, an average vestige cost per medicines dispense was 4.4 euro per dispensing. And the harm study in the Netherlands said that 5.6% of the unplanned hospital admissions were medication related, and almost half of these admissions were potentially preventable. So it's obvious then that to have safer and better medication, there is a need for collaboration in the management of drug use. On health system level, the biggest challenge, the difference between efficacy and effectiveness, this quality gap. When I translate it into pharmaceutical field, it means that the difference between the outcome of clinical trials and how we use these drugs in a real world circumstance. And from pharmacist perspective, the question is, can pharmacists take part in the interprofessional collaboration by bridging these gaps, solving this problem? And how will society and other professionals accept, respect, and reward this? Why should we, pharmacists, involved in this interprofessional collaboration? Because 400,000 cognitive pharmacists are in Europe, and there is 160,000 cognitive pharmacists in Europe. And surprisingly, every day 46 million citizens visit the pharmacy, which is a very huge number. So pharmacists are the easiest available, and if we see the community pharmacy network, the geographically the most widespread network in Europe. And pharmacies can have the contribution to improving public health by maximizing the benefit from prescribed medication to the patient, providing responsible self-care, including when it's appropriate and when it's appropriate self-medication, and encouraging healthy lifestyle. But what is the real concept behind it? The concept behind it is the pharmaceutical care concept, and the first definition of pharmaceutical care was in 1990 by Heppert and Professor Strand, and the original definition of pharmaceutical care is the responsible provision of drug therapy for the purpose of achieving definite outcomes that improves patient quality of life. And then, in years by year, there were modifications like to have the holistic approach, include primary, secondary prevention into this pharmaceutical care process, and also include the economic aspect of that. And also, International Pharmaceutical Association put integrated focus pharmaceutical care issues. But there are differences between country examples and country definitions. For example, in Hungary, in Act of Medicines, we have the holistic approach of pharmaceutical care with primary, secondary and tertiary prevention, emphasizing the collaboration with GPs, with doctors. In the EU, the European Directorate of Quality of Medicines is responsible for the harmonization of pharmaceutical care, and in this definition and in EDQ and concept, there is core thing, the interprofessional collaboration through the medicine journey in every level of care. Last year, the Pharmaceutical Network Europe organized a consensus conference on pharmaceutical care, and the basic sentence was finally that pharmaceutical care is pharmacist's contribution to the care of individuals in order to optimize medicine use and improve health outcomes, but pharmacist's contribution through multidisciplinary approach and targeting individuals. You can say that, okay, there is a concept, definitions. Is there any evidence on that pharmacist interventions are really useful? On the Eurofund Forum website, there is an observatory, and on that observatory you can find published research, also non-published research, country examples, evidence-based articles on pharmaceutical care. I just pick up some literature review when in cardiovascular diseases through the interventions, distribution, better disease control were achieved, or in diabetes care, significant glycosylated hemoglobin reduction were achieved, or in hypertension and many other parts, the intervention of pharmacists were successful. But these are more clinical trials, and clinical trials are different when you want to implement something on a country level. What I would like to highlight is that in many pharmacies there are self-checks available, but what I think it's important that in 11 countries we have medication use review technique through pharmacies, which can really help patient and prevent adverse drug reaction. And also we have new fields like in Norway focusing on anticoagulant drug use because of its very interactive high interaction profile, or in Spain focusing on the drug use by elderly. But behind all these country examples and country approaches, we have international and then implemented to national level guidelines like question to ask about cure medicines, metabolic syndrome, pharmacy-based hypertension management, asthma management. So there are many international and national guidelines. But what is the situation here nearby in Hungary? What are the Hungarian examples? In the last 7-8 years, we had 3 pilot studies, one focusing on antihypertensive field, and we could manage to have significantly decreased blood pressure level in the intervention group. The Hungarian Pharmaceutical Society focused on self-medication and self-care and responsible self-medication and self-care. And what is, I think, important, for example, that to half of the patient, pharmacists suggested different medication than the patient first asked for. Then we should all know the effect of the media on drug use, and in 25% in headache and 10% in sunburn cases of patients were referred to the GP with an official referral letter, which also important when we want to collaborate. And the diabetes prevention program was also successful. We had more than 20,000 documented intervention, and out of that, almost 20% of those patients were referred to the GPs with a formal referral letter and tried to enhance in this way the in-time diagnosis by GPs in diabetes field. To coordinate the situation in Hungary, we organized the Hungarian National Committee of Pharmaceutical Care with the pharmaceutical associations involving all the universities in Hungary. I'm deeply involved in this pharmaceutical care committee daily work and protocol development, and we developed many pharmaceutical care protocols on prescribed medicine dispensing or self-medication dispensing, but we also have disease-specific programs, and we are really proud of that this metabolic syndrome program now is an official ministerial pharmaceutical care activity. And last year, with the collaboration of the GP Scientific Board, we also could manage to have a ministerial guideline on basic level pharmaceutical care activities, and also a ministerial decree on pharmaceutical care and competency issues. Now we have an EU-funded project focusing on the healthcare service quality accreditation and how to enhance the healthcare service, inpatient and outpatient care, and also community pharmacy settings included into that project, which means that the integration into the healthcare system is going well. And in this project, we will develop 15 new guidelines in a collaborative way, which guidelines will focus on the responsible self-medication, for example, in pain, in headache, in gastrointestinal problems, or in chronic parts, hypertension, diabetes management, or elderly drug use, or pregnant women drug use. But the basis is the collaboration. The basis is the interprofessional collaboration, because our patients are in a high risk when they are using more drugs, when they are elderly, when there is a transition between systems, and in many social and cultural affairs. But unfortunately, the research on pharmacists and general practitioners collaboration is not very well-known area. We have existing pilot models in the Netherlands, in Switzerland, or in Australia, but very few research on that project. But some of the studies suggest that the normal or the general model of collaboration could be used in these pharmacists, physicians relationship with this professional awareness, recognition, then exploration, expansion, and the collaborative working model. One European study had deep integration technique with physicians, specialists, GPs, stakeholders, and to be honest, there were many negative remarks on that, but I can totally understand, because in the everyday practice we can see not every time the patient-centered model in pharmacies. But to be positive on Hungary, when we are trying to this collaborative approach in pharmaceutical care, last year we had a survey on that, and the majority of the GPs and the specialists agree on that pharmaceutical care, through pharmaceutical care, the patient gets more information, is useful for doctors, and this is a good way to enhance outcomes. As a summary, we all know that there are challenges in primary, secondary, and tertiary prevention, and because pharmacists are easily available in the healthcare system, we should be involved into that project. And in the last years, there is a very hard development in professional background and daily practice. But we know that we have to work more on that, on harmonization and the everyday implementation, but also there is a need for interprofessional recognition and then collaboration. I really hope that we can work on that. We can work on that collaborative approach because of our patients. So, thank you for your kind attention.